to date. He has been a consultant radiologist in the University of Benin Teaching Hospital since 2002. He joined the services of the University of Benin in 1997 as lecturer 1 in the Department of Radiology, School of Medicine, and rose through the ranks to the position of professor in 2014.
Professor Ademola has held some administrative positions and served as a member of several committees in the university. Some of these include coordinator, postgraduate training, Department of Radiology, University of Benin, Teaching Hospital 2002 to 2004. Member Student Counseling Committee, School of Medicine, 2002 to 2006. Active Head, Department of Radiology, University of Benin, UBTH, 2009 to 2012. Member Central Examinations Committee, University of Benin, 2004 to 2016. Head, Department of Radiology, University of Benin, UBTH, 2016 to 2018. Member Ethics and Research Committee, University of Benin Teaching Hospital, 2012 to 2017. And member
Interfaculty Transfer 2019 to 2024.
Professional associations and bodies, some of which include Fellow West African College of Surgeons, Fellow International College of Surgeons, Fellow Clinical Radiology, German Academic Exchange Service, Member Medical Association, Member Association of Radiologists in Nigeria, Member Medical and Dental Consultant Association of Nigeria, Member Association and Member Governing Board, Radiographers Registration Board.
Professor Adeyekun has over 50 articles in local, national, and international journals, with research interest in ultrasonography and neuroradiology. He has attended several national and international conferences. He has served as a member of various accreditation panels of the National Universities Commission of Nigeria. Professor Adeyekun has served as external examiner to various universities and the Faculty of Radiology, West African College of Surgeons. He is an assessor of candidates for professorial ranks for many universities. He has trained over 40 diagnostic radiologists and supervised 34 postgraduate dissertations. Thank you. For the National Postgraduate Medical College and West African College of Surgeons, Professor Adeyekun loves exercising, watching historic documentaries and conflicts, and has passion for football. He's a fan of football. He's married to Mrs. Adeyekun, and the marriage is blessed with 3 children. On behalf of Madam Vice Chancellor, ladies and gentlemen, it's my pleasure to invite you all to invite Professor Adeyekun.
Good afternoon. On behalf of myself, my family, my colleagues, our dear Vice Chancellor, for giving you the present challenges. I would like to stand on already established protocol. The title of this inaugural lecture, Invisible Rays, Silent Sounds, and the Rewards for Chasing Shadows, took me many months to come up with. In fact, the title came after the first submission of the manuscript. But I will explain the choice of this apparently interesting title. The lecture is dedicated to the memory of my parents, protocol already established. Yes, this is the 315th in the series of inaugural lectures of the University of Benin and the third from the Department of Radiology, as mentioned. The topic of this lecture is
silent sounds and the rewards for chasing shadows captures the essence of the practice of radiology, a specialty where the radiology makes substance out of shadows. These shadows are created by invisible rays and silent sounds. The lecture specifically summarizes my research experience in conventional radiography, ultrasonography, computed tomography, radiology education, residency, training, and hopefully will provide some insight about the specialty and the practice of radiology itself. By way of introduction, we go into a bit of history. The practice of radiology commenced in November 8, 1895, when Wilhelm Conrad Röntgen discovered X-rays while studying the properties of electrons in a cathode ray tube from which much of the air has been removed. He removed the air from the tube so that there won't be collision between the air particles and the electrons that will reduce their energy. Additionally, he shielded the tube by cardboard to block any effect that light may have on his experiments. So he thought he had a foolproof arrangement. He had covered the glass envelope with dark cardboard to remove the effect of light, and also created a vacuum in the envelope so that air will not collide with the electrons. He was therefore surprised at a faint glow of fluorescence on a barium-coated paper on a nearby workbench when the tube was energized. So he concluded that something hitherto unknown, a type of rays, was produced when the cathode ray tube was energized, hence the name X-rays. As we all know, X in algebra stands for unknown. So that is the origin of the popular word or popular label X-ray that we have today. He could have named these things after his parents, his mother, his father, his spouse, himself, his daughter, his village, and so on and so forth. He didn't do that. What a humble man. To further confirm the existence of this unknown rays, which was invisible anyway, various objects were placed between the tube and the screen, including his own hand. Emphasis on including his own hand. I will come to that later. And each time, images of the object in various degrees of brightness was recorded each time, meaning that these rays are able to penetrate some objects more than others. That's why you have the varied appearances of the objects. Finally, on December 22nd of the same year, he held his wife's hand between the tube and screen, and the outline of her hand skeleton appeared on the screen. This was actually the first recorded human radiograph. As can be seen there, see the Frau Röntgen, Mrs. Röntgen's hand with the wedding ring and all sorts. This was the first recorded human radiograph. As I said earlier, before this time, Röntgen put his own hand, but tomorrow nobody have cited the literature. I cannot find the radiograph of Röntgen's hand, meaning that this matters of who comes first has been on for centuries, and we need to find out from medical historians what actually happened, that maybe the matter started in, according to Bubu, the other, whatever. So by December 28th, a week from that date, he submitted his manuscript. This was published within 2 weeks of submission in a local journal. Madam Vice Chancellor, if I publish whatever I feel is outstanding,
probably Google Journal of Radiology and Radiation Science, edited by my dear friend, Professor Tito, IBB. I am not sure If you survive departmental A and C screening, not to talk of central A and B. But that was what happened there.
Throughout this period, as you can see, he kept chasing shadows and he got his reward. First, the title of the manuscript then was Über eine neue Art von Strahlen, meaning on a new kind of rays. So news of discovery spread like wildfire, and the man instructed that nobody, no system should patent his discovery. Nobody should commercialize it. In recognition of this outstanding discovery, as his reward for chasing shadows, first, the University of Würzburg, that earlier denied him admission into a PhD program in physics, instantly offered him chair of the same department. That is the number one reward for chasing shadows. Second, he became the first laureate, the first Nobel Prize winner for physics in 1901. Of course, most important, his discovery revolutionized the practice of medicine. You don't need to open up the human anatomy before you know what goes inside. That is what some of my friends present in this garden tell me every time, that I can look inside the human being, that my friends should be aware that each time I look at them, I'm seeing the very inside. So let's define these invisible rays. X-rays are produced by energy conversion, when fast-moving electrons produced at the heated tungsten cathode or the negative filament, accelerated by potential difference, are suddenly stopped at the copper positive terminal or target of an X-ray tube. They are a member of the electromagnetic spectrum, and they are of dual nature, particles and waves. In imaging, we are concerned about the particulate aspect of these X-rays. That is the electromagnetic spectrum. In the middle there, see visible light. Towards the left, you have this low energy, non-ionizing, apparently safer, forms of a electromagnetic spectrum. As you move towards the right, you have the more penetrating, more ionizing, maybe not as safe as the others. Then you can see X-rays there before gamma rays and the others. So now, silent sounds. What do we mean by silent sounds? So, these silent sounds do not involve ionizing radiation. That makes them, so to speak, safer than the other invisible rays. Pulses of high frequency, beyond what the human ear can detect, that is why they are silent. And that's the explanation for the near oxymoron of silent sound. Sound should make noise somehow, but this one, because the human ear cannot detect them. The human ear has a limit, human hearing has a limit of 20,000 cycles per second, or 20 hertz. Now we are talking of mega, so there is no way the human ear can pick them. These sounds are emitted from a transducer held against the patient's skin. Okay? Now, let me explain some terms. The more technically acceptable term for what we refer to as X-ray is actually a radiograph. Okay? This radiograph is produced when X radiation passes through a patient. The X radiation is attenuated to varying degrees, leading to different patterns, which is for more or less a grayscale format on a film. So, with the illustration there, so if you look at this chest radiograph now, those areas that appear bright, which we call, we say they are opaque, okay? Those parts of the anatomy stop the radiation from passing through, compared to those areas that appear, those areas that appear dark, okay? Which we call lucent areas. Those lucent areas in the chest represent air in the lungs. They hardly stop the beam from passing through. So they darken the film. Unlike bone, I'm pointing to the rib here, the rib cage, this one stops the radiation more than air. So they appear opaque, bright on the radiograph. Now, computed tomography also involves ionizing radiation. But in this instance, a piece of tissue, a slice of tissue, is scanned from multiple angles by the X-ray beam. In fact, in computed tomography, you actually slice through the tissues the way you slice a loaf of bread or yam tuber or any other potato in that format. Okay? So the difference now is that the computer is involved, unlike in conventional radiography. So the computer assigns attenuation value, which is more sensitive than what you have in plain radiography, sums up and reconstruct the composite image in a grayscale format on a television monitor. It is the same thing at the end of the day, grayscale appearance. You have dark areas, you have bright areas. The only difference is that if you look at this image, the one to the left, okay, also to the right, those areas that look very opaque, very bright, that is the vault, that is the skull bone, okay? If you move towards the middle, you see brain tissue. Not as bright as you have for the vault, but not as dark as the fluid in the brain, which you call the ventricles. Again, a difference of which one stops the beam from passing more than the other one. So it is clear here that the skull vault attenuates most of the beam, whereas the fluid in the ventricles do not attenuate as much. So we describe the appearance when they are dark as hypodense, when they are bright as hyperdense. In ultrasound, I've explained earlier, sounds of high frequency emitted from a transducer housed in a probe. Some of us have done ultrasound before. That thing like the head of a cobra connected to a probe, that is the connected by a cable. That is the probe we use in ultrasound. It has the transducers. So electronic analysis pick the returning echoes from tissue and also builds an echo pattern in a grayscale format. Okay? So the areas that appear bright here are described as hyperechoic, and the areas that appear dark are described as hypoechoic. In magnetic resonance imaging, this too does not involve any ionizing radiation. Okay? The living tissue, the human, the plant, the animal, the most naturally occurring chemical in all forms of life is water. Water is composed of hydrogen ions and hydroxyl ions when it dissociates. The hydrogen ion is a proton. Positively charged particle is a proton. And when a charge moves, it produces current. One of the effects of current is magnetism. So, as we are all seated here, all living tissues, plant and animal, we are composed of billions of tiny magnets waiting to be utilized until one man called Latabo did some experiments. Anyway, so when you put this living tissue into a huge bar magnet, okay, the magnetic pole aligns with the main field. Then you send in radio frequency. As soon as you send it in, you withdraw the radio frequency, and the patient emits a signal, which is used for reconstructing the image. So again, it can be hyper intense, or high signal, or bright, or hypo intense, or low signal, or dark, depending on your preference. In scintigraphy, a radiopharmaceutical is taken orally or injected intravenously and is taken up by target organs depending on the vascularity. So this radiopharmaceutical emits gamma radiation, which is possessed by the computer and recorded by the gamma camera. Now, we often confuse the terms radiology, radiography, radiographer, radiologist. We are cousins working to achieve the same purpose. A radiologist is the team leader in the imaging or radiology or X-ray department, if you like. After completion of full registration, radiologists will do a CCR residency training leading to the fellowship. His job is to interpret and report the images and to undertake or supervise most special procedures. A radiographer is a university graduate who is in radiography, who is trained and skilled in exposing patients and processing the image for reporting or interpretation by radiologists. Like I said, we are cousins. We work to achieve the same goal of helping the patients. But at least there has to be somebody in charge of the whole process or department. So, state of radiology in Nigeria. A 2015 survey reported that we had between 250 and 300 radiologists for the whole of Nigeria. As at that time, that translated into one radiologist for over 500,000 people. Following JAPA that we have now, that is already established now, I'm sure it will be one radiologist for every 1 million of our population. I can see some of my fresh fellows smiling in front of me now. They already planned. But I keep making them that some of them should stay behind because
they should stay around.
So in the last 5 years, there has been some improvements because we used to have obsolete equipment in the department until Vamed came, but I'm not sure things are improving any further. Although we have increasing numbers of 1.5 Tesla MRs across the country, but most of these digital units, CT scanners, and MR units are in the urban centers, Lagos, Abuja, Port Harcourt, maybe Kano or Enugu, but not in the semi-urban areas. Yes, my professional and academic contributions. I was appointed lecturer in 1997, and there was a 5-year gap before I was made a consultant. The reasons for that will be a story for another day. I was nonetheless undeterred, and as today, by the grace of God, I've been involved in the training of over 40 radiologists, including professors, academic staff, and consultants. And I am proud to have seated in the audience here one of my Professor Kenneth, Professor of Radiology and Dean of Faculty of Sciences, Nnamdi University. Professor Ademola, I'm very proud of you. Thank you very much. 35 dissertations, still counting, and I've been an examiner for the past 1.5 decades. Yes, so what have we learned from Rongen? How far have we succeeded in getting rewards for chasing shadows? Because either you do plain radiography, computed tomography, ultrasound, nuclear medicine, magnetic resonance imaging, what you have, as you have seen from the few images presented, are shadows. But like I said, we are trained to make substance out of these shadows. So, first, in the area of obstetric radiology, gestational age estimation is important to the obstetrician because accurate estimation of gestational age or the fetal weight is very important. The obstetrician needs the optimal time for delivery of the fetus. Okay? So there are many parameters for estimating the gestational age. There are already established ones like the biparietal diameter, femur length, abdominal circumference. But the one we worked on, transcerebellar diameter, TCD for short, is an emerging parameter, fetal biometric parameter, for which data is scanty among Africans. So we worked on 400 healthy pregnant women, that's Oji and Adeyekun. We measured the transverse cerebral diameter in 400 healthy pregnant women so as to determine the accuracy in calculating gestational age and also to compare with other established parameters to see if it has a higher predictive accuracy. In the images before us, to the left, that is the cursor showing the width of the fetal cerebellum as measured across. Okay? The cerebellum is the small brain. Actually, in German, the German word for cerebellum is Kleingehirn. Klein means small, Gehirn means brain. So the Germans refer to the cerebellum as small brain. If you look at this one, because we also studied the appearance of the cerebellum. Here, it looks like a modified pair of glasses, but here, the one on the right, illustrated by the green arrow, shows the cerebellum, fetal cerebellum, as a kind of dumbbell appearance, which some cheeky individuals refer to as resembling an interesting part of the male anatomy. Too sensitive for this type of discussion, so we are going to skip it. What did we report? Or what was our reward for chasing shadows? There was significant correlation between TCD and menstrual age. Okay? High correlation value, very significant probability. This was reported by Oji and Adeyekun in 2014. And we also reported that TCD has a higher predictive accuracy compared to other established biometric parameters, especially in the second trimester. This was reported by Adeyekun and Oji, the same 2014. To the best knowledge of the authors, this was the first report on ultrasound estimated TCD use among Africans. And it has attracted many, many citations. Thank you very much. That is the nomogram we constructed for the TCD. So our recommendation was TCD should be included in fetal biometric calculations in ultrasound machines. It has a higher predictive accuracy than other fetal biometric parameters. We also use placenta thickness to estimate gestational age. Physiologically, the placenta is the link between the mother and fetus, responsible for carrying oxygen and nutrients. It therefore important to know that disease of the placenta will impact on fetal growth. And literature has shown that placenta thickness can be measured sonographically using the method of Hoddick and Associates at the mid portion. This is the placenta here, okay, where the cursor points to, that is the same appearance. The placenta is brighter somehow. You appreciate that it's brighter than the darker shadow below it, which is the amniotic fluid. So we measured the placenta and we reported that, Adeyekun reported that the thickness ranged from 26 millimeters at 15 weeks to 39.2 millimeters at 40 weeks. And I reported the linear relationship between ultrasound measured placenta thickness, fetal biometry, and GA. The recommendation was placenta thickness measurement should be an additional parameter for fetal biometry. In a related study, ultrasound study, Adeyekun and Ikubo sonographically assessed the relationship between PT and estimated fetal weight in the different cohorts of pregnant women. And this study showed that placenta growth has a direct relationship to estimated fetal weight. In other words, if there is increase in fetal weight, then or increase in placenta thickness should be accompanied by increase in fetal weight. There should be a direct relationship between the two parameters. This was reported by Adeyekun and Ikubo in 2015. Dr. Ikubo should be here, but because she had some gist about what is happening, she told me she apologized that she may not be able to make it, but it's okay. We also used amniotic fluid index and estimated fetal weight to test if there is any relationship between them that may be relevant in obstetric practice. The amniotic fluid physiologically, which we all know as the four waters, cushions the fetus from traumatic, infective causes, cord compression, and also plays an essential role in fetal lung development. Because changes occur in amniotic fluid index and the estimated fetal weight, especially in late pregnancy, we thought there could be a possible relationship between these two important parameters in pregnancy. So we assessed a relationship between them. We studied 2, 4, 8 low-risk pregnancies. But what we reported was that while EFW and AFI showed variations in values in late pregnancy, there does not appear to be a direct relationship between the two variables. In other words, we don't need to bother about fetal weight in late pregnancy when we see variations in amniotic fluid index. This was reported by Adeyekun and Awosonya in 2013. Next, we also studied the endocrine system, still chasing shadows. That is what we are trained to do. In Yoruba, we say, you don't beat a dog, you don't scold a dog for barking. So don't blame a radiologist if all his life he keeps chasing shadows. That is what he's trained to do. Thank you. We studied the diabetes mellitus and the thyroid gland. We know that diabetes mellitus is a multisystemic disease. Practically all the organs in the body can be involved. It's a disorder of glucose metabolism. We know the thyroid gland as that little soft tissue at the root of the neck below the Adam's apple. But there is a reciprocal relationship between these two entities. Not a particularly good one, because thyroid disease can worsen sugar control in diabetics. Okay, glycemic control may be much more difficult. On the other hand, patients with diabetes mellitus have increased incidence of thyroid disorders, thyroid gland enlargement, development of nodules or tumors. So we try to study what exactly is the situation with diabetics compared with non-diabetics as far as the thyroid gland disorder is concerned by means of ultrasound. Nduka and Adeyekun, 2016-2017, sonographically assessed the thyroid gland in 120 diabetes subjects and an equal number of non-diabetic controls. What did we find? Diabetes has significantly increased thyroid volume or size compared to age-matched male and female control subjects. This increase in gland size is thought to be due to gland proliferation from circulating insulin, and there was no influence of gender on these measurements. In other words, between the male and the female genders, there was no significance. This is the thyroid gland traverse scan, the thyroid gland in longitudinal scan. The green circle in the top image actually highlights a nodule, a growth, a tumor within the thyroid gland. So when we see tumors, Professor Ogiagbe is seated here. The next thing is you want to determine is it malignant or benign so that it will influence patient management. Although we detected nodules in both diabetic and controlled subjects, diabetes had significantly higher number of thyroid nodules than non-diabetics. Again, this was not influenced by gender. So our recommendation was that routine thyroid gland sonography should be done for patients with diabetes so that when you notice increase in gland size or nodules, these nodules or even the gland itself should be subject to biopsy so as to differentiate benign from malignant ones. This will definitely influence patient management. This was reported by Nduka and Adeyekun and Nduka. So this will interest not just diabetics, but those of us who have accumulated some extra in the arterial part of the abdomen. I can see Professor Onigbe smiling. So it's been long recognized that subcutaneous fat accumulation can complicate diabetes mellitus. It is just that the clinical significance remains controversial. So Adeyekun et al. Decided to comparatively evaluate by means of ultrasound anterior abdominal wall subcutaneous tissue thickness, AAST for short, in 150 adult diabetics and equal number of normal glycemic subjects. And we reported that adult diabetes had significantly higher AAST values compared to age and body mass index matched male and female apparently healthy control subjects. So the implication of this is that increase in AAST in diabetics can be a useful guide in the management of obesity in this group of patients. This was reported by Adeyekun, Okoje, Munir Abubakar, and Efe Aluta in 2016. Yes, this is a very interesting one. The only case report I have for this presentation. And it should stimulate the interest of those of us who consume porcupines,
bushmeat generally, and whatever name you want to give them. Some of these
parasites, and some of these parasites are actually die hard. Most patients will escape because they are asymptomatic, but in a few we've been able to identify or diagnose some of these things that hitherto used to be well-kept secrets. Thank you. So, in 2011, we reported a case of Amylifer amylatus in a 57-year-old farmer who was a regular consumer of snake meat. The patient never told us that he or she was eating snake meat regularly. Just presented with tiredness, cough, mild, a tinge of jaundice, and loss of appetite. So one thing led to the other. The chest X-ray was done. This may not be very clear, but you see some dots in the lower part of the chest. Okay? Some tiny opacities in the lower part of the chest. Then the one below it is the CT scanogram. Okay? Chest and abdominal radiograph show multiple crescentic or comma-shaped calcific densities. Those chalky white stuff all over represent the calcified larva of the parasite. The man has eaten the snake meat is digested, but the stubborn parasite remains in the body because it stays in the central nervous system of the snake. The snake is gone, long digested. So the parasite keeps producing the ova. The body cannot handle the ova by the simple means of digestion. Before you know it, the parasites go through the subperitoneal layers, subpleural layers. They are all over the chest and abdomen, especially in this patient. So when you look at the CT, it is clear. This image, the top image here, shows significant hepatic enlargement. This patient actually had some hepatic fibrosis. Apparently, that could be responsible for the little jaundice we noticed in this patient, but eventually the patient recovered. You can see the calcified parasites, the liver, the omentum, the rectum, the bladder, in the walls of this organ. That's where it stays. So we recommended health education regarding the potential risks associated with Amylifer infestation for individuals who regularly consume snake meat. The interesting part of this article was that not too long after it was published, a German wrote me, a German medical lab scientist, and asked whether I could send serum samples of some of these patients. And I replied him instantly. I said, you should get a letter from the German Customs, the German Ministry of Interior, the German police, and the embassy in Nigeria here, because I know one thing for sure. As soon as I land at Frankfurt Airport and detect serum in my, I'll be arrested and detained immediately. There was a time they actually searched my luggage.
You know, I must take Garina, waiting man to chop. So they asked me, they said, Bas, this? What is this? I said, it's a step in Nigeria, so I put it in my mouth. They let me go. The man, after I replied that email, he never wrote to me again. Because he and me, the man will be enjoying his life.
Please, let us be careful. The habit of consuming anything from the bush, we should control it and also help to conserve the ecosystem. I can see Professor Ademola there. I know you'll be happy. I don't know if Professor Kalu is here, but they are my friends. They'll be happy that I'm trying to preserve the ecosystem. So, in the area of renal radiology, we also try to chase some shadows there. We also had the belief that before you can appreciate abnormalities or morbidities in a particular organ, knowledge of the normal appearances and size is very important. So knowledge of normal range of kidney sizes in neonates is important in assessing variations that may occur from morbidities in the newborn period. Adeyekun, Ibadin, and Omogberale conducted a prospective study, ultrasound study on renal size in healthy term neonates, reported a mean renal length of 44.6 millimeters, and reported a strong correlation between the weight of the neonate, the length or height, and renal size. This was the first reported ultrasound study on estimation of kidney sizes in newborn among Nigerian Africans. Thank you. Thank you very much. So, our gain, our reward for chasing shadows in this instance was we constructed a reference nomogram for neonatal renal sizes in Nigerians. Next, in the renal system, we studied the effect of HIV/AIDS on the kidneys. When an individual is afflicted by HIV or AIDS, manifestations of renal disease, which can be seen in some of them, are thought to be due to, reported largely to be increased in the size of the kidneys and increased brightness of the kidney on ultrasound, what we call increased echo texture. So the kidneys can be enlarged or they may be brighter than normal in individuals who are affected by HIV/AIDS. And these manifestations are thought to be more profound when the CD4 count, which used to be the indirect measure of level of immunosuppression, is very low. So we try to find out, should we bother about renal sizes and increased echo texture when the level of immunosuppression is very high? Okay? In furtherance of this, we assessed the kidneys in HIV/AIDS and found that large increase in renal size and increase in renal echogenicity were not common, even when majority of the cases we studied had low CD4 cell counts. We still did not find many cases with large kidneys and increased echo texture of the kidneys. So our message was that renal size and echogenicity alone may not be useful predictors of severity of renal involvement in HIV/AIDS. Because the renal size is increased or the kidneys are brighter does not mean that the renal system is severely compromised. That was the message. This was reported by Adeyekun, Unuigbe, Onunu, and Azubike in 2011. Getting into the subspecialty of respiratory radiology, mantle tests, many of us present at this gathering must have been asked to do a mantle test either for employment purposes or you want to travel outside the country, or some individuals suspected to be exposed to tuberculosis. Okay? But the truth of the matter is that the mantle test just tests your antibody response to the tuberculin antigen. It does not mean that the person has active pulmonary tuberculosis. Okay? So, as radiologists, we are not just interested in changing shadows. We are also interested in cost of these things to the patient, and more importantly, safety. The issue of safety is paramount. So, in consideration of this, Adeyekun and others conducted a study on the yield of positive radiographic findings in a cohort of 174 patients who had mantle tests for various reasons. Our findings show that out of 102 subjects, that had positive mantle reaction, only 27 or 31.1% had abnormal chest radiographs. Thus, there was no significant correlation between mantle readings and chest radiographic findings. we then advise that sputum and interferon tests, maybe gene expert, should be done as follow-up examinations for mantle-positive cases before you do chest radiography. We also studied incidence of Kaposi sarcoma in the chest of patients involved in HIV/AIDS. And out of 33 patients we studied, only 15 had abnormal chest radiography findings, even when the mean CD4 count was very low. Therefore, our message was pulmonary involvement in Kaposi sarcoma does not have a significant relationship with the level of immunosuppression. This was reported by Adeyekun, Onunu, Ukonu, and Okubo. Radiology, we studied head trauma cases using CT. Our findings show that skull fractures and intracerebral hemorrhages were the most common abnormalities. This blue arrow to the right shows skull fracture, and the one in claret shows abnormal blood connection in the brain. Skull fractures and intracerebral hemorrhages were the most common abnormalities found in this study. So we also studied used CT to assess patients with stroke. Cerebrovascular accident carries a very high mortality, especially the hemorrhagic type. Okay, and clinical outcome for the patient depends on prompt imaging diagnosis. We therefore decided to study CT features that may predict outcome in 81 Nigerians with hemorrhagic stroke. We found that mass effect, that's when the brain shifts from one side to the other, intraventricular extension, perlusional edema, are the CT changes that adversely affect outcome in hemorrhagic stroke. This top image here, the bright area, shows fresh blood into the brain, hemorrhagic stroke, and the lower one, extension into the ventricles. In musculoskeletal radiology, we assess the hip replacement by prosthetics. We found out that, or it is known that most of these replacements carried out for designs based on studies from Caucasians, and this has implication for our patients. So we studied the normal angles of the hip for our patients, and we found the values to be 121 plus or 28 degrees for the CCDA and 80. That's the hip angles. And we recommended more extensive studies, especially with CT and ultrasound, to establish more appropriate design angles for our population. We cannot be relying on Caucasian data alone. Madam Vice Chancellor, we all know that whenever students are given admission or people are employed, the next thing they should do chest radiographs, whether they are symptomatic or not. And again, for reasons of cost and safety, Ogbedi and Adeyekun carried out a study to assess the yield of routine pre-admission chest X-ray among close to 4,000 newly admitted students of University of Benin and UBTH. Out of 3,859 students, only 11 had abnormal cases, showing a very low diagnostic yield. Again, we advise that chest radiograph should only be requested when sputum assay, ECG, gene expert, and others are abnormal. But for reasons of commerce, again, these things are really, these recommendations are really taken into cognizance. Adeyekun Adeyekun and others assessed factors affecting patients' access to imaging services in 2004. It's been reported that out of 7 billion people in the world, only 4 million, about 4 million, will have no access or limited access to imaging tools. And if the machines are there, you may not have the radiologists and the technicians. So Adeyekun, Uyagu, and Obaze studied these factors affecting patients' access, and we discovered that cost was the main problem. Of course, that stands to reason, followed by non-availability, and this limited access greatly affected patient management. We recommended subsidized services via health insurance as the panacea to this problem. Yes, government started health insurance, but whether it's working well is another story altogether. In an earlier study by Adeyekun, it was reported that a well-advocated, well-planned, adequately funded health insurance scheme will be a remedy for addressing the non-availability of MRI in this country. This was 2003, as at that time, only National Hospital Abuja had an MRI facility. postgraduate training in Nigeria, radiology training in Nigeria has been of great concern, bearing in mind that if the residency training program is not well structured, is not well funded, then you are not going to produce quality radiologists for the country. So I assessed the perception of radiology residents about the program with emphasis on equipment, curricular, library facilities, and faculty, among others. And residents responded that non-availability of modern imaging gadgets, limited opportunities for overseas training were the major problems the program then. Today, partly because these recommendations have largely been ignored, a number of resident doctors early stayed to complete the program, migrating or jackpotting to UK, US, and Canada. In the last 5 years in the department, we have lost between 4 and 5 residents. They have all left. They didn't bother to even complete the program. It remains a problem. Yes, Madam Vice Chancellor, the practice of radiology is beautiful, but requires massive funding, billions of naira, for a single department to function effectively. As of today, the CT scanner costs on the average 500 million, an MR scanner about 700 million. The cheapest in our diagnostic arsenal is the ultrasound machine, which costs around 50 million. So, Madam Vice Chancellor, if tomorrow you approve a grant of 50 million for a department in the university, while others will hold parties, they will shout hallelujah, they will praise management to high heavens. In my department, all we show is just one murmur. Okay, they don't try. Because we will struggle to buy just
department with that 50 million. Madam Vice Chancellor, I would have been
small department, but as we say in Yoruba, kikere.
The needle is very tiny, but that's not an excuse for the fowl to mistake it for a grain of rice. Thank you very much, sir.
Therefore, we need to revisit the health insurance scheme. It should be comprehensive enough. Cooperation between the universities, state fund, ETF, and teaching staffs should be improved. In this wise, I want to thank you, Madam Vice Chancellor, because things have improved in the last 4 years between UNIBEN and UBTH. Before this period, it used to be, it's university, it cannot stay. But in the last 3-4 years, we have 2 buildings already commissioned in use, lecture theaters. 2 more buildings are already at various stages, so almost completed. And I want to plead, Madam Vice Chancellor, that urology lab there should not be allowed to waste. Please, it should be put into use. And that can only happen if the university and the hospital cooperate. That place has theater facilities, everything you need in a modern urology practice. But somehow it's not being put into use. Donations from public spirited individuals, if we can get them to donate to us, that will be helpful. Then public-private partnerships. But there's a caveat. Training should not be compromised. Because most of the PPPs around, the people who just bring the machines, they want to recoup their funds and run out. They even tell you that only one consultant or only one resident should be part of the management of that. That will not go well for training. And with due respect, Madam Vice Chancellor, this individual standing before you, with due respect, will not support any PPP that compromises on training. Yes, the College of Surgeons and the National Postgraduate Medical College must step up their efforts in training more radiologists for Nigeria and West Africa. The 1-year abroad program should be reintroduced, or in the alternative, sponsorship can be provided for such deepening of knowledge at well-equipped centers locally and in the sub-region. Primary health care, basic ultrasound machines should be provided at primary health care centers to improve obstetric care. Mammography facilities for breast screening in women above 40 years. My colleague talked about that last month. And public enlightenment on the potential risk of unnecessary exposure to ionizing radiation. Please, I want to appeal to the distinguished audience. We should stop going to doctors.
Department that I want to do X-ray. This place, they pay me. you should see your doctor first to determine whether it is really necessary for you to do the radiograph, because you don't want to expose yourself to ionizing radiation when it's not necessary.
This lecture has highlighted how the lecturer, through his research, has used the intriguing shadows created by technological manipulation of invisible rays and silent sounds to contribute to knowledge in improving patient care by creating nomograms and identification of specific alterations in some organs and disease conditions. I also identified the impediments to the practice of radiology in this lecture. Acknowledgements. Madam Vice Chancellor, I thank you most sincerely for giving me the opportunity to give this lecture. I must also thank the Almighty God for all He has done for me. I never thought I could go this far in life, especially against the background of very humble beginning. I am not trying to whip up sentiments, but after the promotion in the primary school, I could not go to secondary for 15 months because of paucity of funds. But thank God, I got to where I am today. I also thank the current Vice Chancellor for piloting the affairs on this show in a very amenable way. There is VAR. VAR must visit this at that time. Please. All the previous Vice Chancellors are appreciated, especially Professor Ademola A, who granted me graciously 18-month study leave with full pay in 1999. Otherwise, it would have been difficult for me to access the German educational system. May God bless him. I acknowledge the past and present CMDs of UBTH for providing the facilities which some of these studies presented were carried out. Though the gadgets were limited, there was a particular journal, myself and Oguni, we sent a publication to, Stroke, that report on hemorrhagic stroke. And they asked us two vital questions. What is the age of these equipment you used? Question number 2, how many of your patients presented within 24 hours of the onset of symptoms? We could not answer the questions. Okay. So, I thank the provost, I thank Professor Ibadi, blessed memory, I thank my parents, I thank my wife. I must mention Professor Dr. Olumide Okikeolu introduced me to radiology. I also thank Dr. Eke Arawa, who taught me radiology, the basics of radiology. I'm grateful to her. I thank Dr. Bekakoka of Blessed Mary and Dr. Ajudua, Beckett Remo. Professor Riza, I thank my wife for 32 years. She's present here. She's the one who can recognize my younger brother is here, my family, my constant department. Thank all of you who have trained police in the senior staff club. Senior staff club, where are you? I thank all the session. Thank you. Thank you. Thank you.
Celebrate our lecturer. Celebrate our excellent A+ lecture. Put your hands together for our lecturer. Thank you very much. Please be seated.
Deputy Vice Chancellor Administration, Professor Catherine Obama. Please put your hands together for her. May I now respectfully invite the Acting Vice Chancellor, Professor Ademola A, to give a recap of the lecture. Please put your hands together.
Great to be here. I want to believe we've had a very wonderful lecture. The lecturer told us that radiology has revolutionized medical practice for over a century with rapid, continued improvement in imaging facilities. The reliability of diagnostic imaging is of vital importance to accurate diagnosis of many diseases and definition of normal anatomy. The lecture addressed the introductory aspects of imaging modalities like conventional radiography, ultrasonography, computerized tomography, and magnetic resonance imaging. It discussed how invisible rays and silent signs produce shadows that help in providing insight to some organ evaluation and disease conditions. This inaugural lecture discussed the lecturer's contributions to diagnostic imaging by highlighting the messages in publications. The challenges of optimal imaging diagnosis and research are equally mentioned. The lecturer offers some recommendations aimed at overcoming the challenges that he mentioned earlier. These include improved funding, which must include comprehensive healthcare, cooperation between universities and teaching hospitals, donations from philanthropists, and quality public-private partnerships. Equally mentioned as part of the recommendation, training of medical doctors, both at West African College of Surgeons or National College of Postgraduate Surgeons. These should be encouraged. Equally mentioned, exposure to 1 year abroad program, which should be encouraged to sharpen the skills of radiologists. Equally mentioned, provision of state-of-the-art equipment to aid training, understanding, and practice of radiology down to primary health care in our country. He has told us that comprehensive understanding of invisible rays, silent sound, and shadows definitely assist doctors to diagnose many ailments, including those with no physical signs. Ladies and gentlemen, on behalf of Madam Vice Chancellor, I want to appreciate every one of us and recognize our presence in spite of all odds, particularly the protest that we had on campus some few hours ago. I want to, on behalf of Madam Vice Chancellor, recognize all our security men, as well as security men from outside the police, the SSS, and in particular Venerable Adegusi and many other persons that contacted the security men to make this lecture a reality. We equally appreciate Madam Vice Chancellor, who, because of what has been happening since yesterday, became worried that to the extent that about 1.5 hours to the beginning of the lecture, she had to call whether we'll be able to make it. And we told her, by the grace of God, we'll be able to make it. She proceeded to call the Commissioner of Police. Nothing will happen to tamper with the integrity of this lecture. And to every one of us present here, I want to say thank you. God bless you.
Chancellor Professor Ademola A, the acting Vice Chancellor.
And we invite the immediate family to come up stage to support him as he gets decorated. Please come up stage. Brother, you can also come up stage. If his brother is here, you can come up stage as well. Thank you very much. While that is going on, please put your hands together for the support of our lecturer, Mrs. Adeyekun. Also put your hands together for the children of our lecturer, Barrister Adeyekun, Barrister Adeyekun, daughter, please put your hands together. Thank you very much. Also put your hands together for his cousin, Dr. Adeyekun. Put your hands together as well.
Please put your hands together. Thank you very much. Professor Emeritus Bob.
Past librarian of the university, Professor Luke Obasu, you're welcome. Please put your hands together. Former Deputy Vice Chancellor of Ekewan Campus, Professor John Eria, put your hands together. You're welcome, sir. Professor Patrick Owaja, you're welcome. Professor Afe Ide Omoto, you're welcome. Please put your hands together. Professor Matthew Enoso Nashep, you're welcome. Please put your hands together. Professor Paulino Sumoto, you're welcome. Professor Oladipo Esquire, you're welcome. Please put your hands together. Professor Mrs. Esome Omoyo, you're welcome. Professor Chijoke Ndame, you're welcome. Professor G. Atelo, you're welcome. Please put your hands together. Thank you very much. Professor Mrs. Sakai Joy Mikele, you're welcome. Professor Frank Imaraga, you're welcome.
Please put your hands together. Please put your hands together. Thank you very much, Professor Ademola. Welcome, sir. Professor Mrs. Caroline Olorunmori, you're most welcome. Dr. Folai Dimo, you're welcome. The chairman, Ehiga, Enabu Doso, and members, you're most welcome. Please put your hands together. Put your hands together. Thank you very much. All staff of the Radiology Department, UTH, you're welcome. Members of the 1979 Silver Jubilee Set of Omanawa Memorial Grammar School, Ondo State, led by the President, Mr. Welcome. Please put your hands together. Distinguished ladies and gentlemen, that's how we conclude the 315th in the Inaugural Lecture Series of the University of Benin. Please put your hands together. The Union Anthem. The national anthem. Session is the auditorium.